Welcome to this video entitled Respiratory System Case Studies. Next we will discuss Case Study Level 1 focusing on asthma in the community. Let's begin with learning outcomes. On completion of Level 1 case study, you will be able to accomplish the following. 1. Describe the risk factors. 2. Describe the disease. 3. Describe the pharmacology of the drug. 4. Outline the formulation, including drug molecule, excipients, etc. for the medicines. And 5. Summarize basic social pharmacy issues, e.g. opening containers, or large labels. Let's briefly look at a clinical scenario. An 18-year-old man, VB, presents with a history of recurrent episodes of wheeze after walking 200 meters. VB has recently started to go to a gym and his episodes of wheeze have worsened. He goes to see his general practitioner. He can talk in sentences but his respiratory rate is increased. His peak flow is 420 liters per minute, which is 80% of predicted result. A diagnosis of mild asthma is made. He is started on salbutamol metered dose inhaler, abbreviated as MDI, 2 puffs when required, and beclometasone, Q-VAR, 50 micrograms twice daily. Question 1 reads, what is asthma? Asthma is a chronic inflammatory disease affecting the airways. Symptoms are cough, wheeze, a feeling of tightness in the chest and shortness of breath. Asthma is characterized by the following. 1. Airway obstruction, also known as bronchoconstriction, which is usually reversible either spontaneously or with therapeutic intervention. 2. Airway hyperresponsiveness to a range of stimuli. 3. Inflammation of the respiratory bronchioles due to eosinophils. T lymphocytes and mast cells are involved in the production of mucus, edema, smooth muscle hypertrophy, and this can lead to mucus production and epithelial damage. If asthma is chronic, it can lead to inflammation associated with irreversible bronchoconstriction. Asthma can be classified as either extrinsic or intrinsic. 1. In extrinsic asthma there is a known external stimulus. This is usually in patients that are atopic and show reactions to allergens. This is common in childhood asthma too. In intrinsic asthma there is a causative agent identified. This usually starts in middle life, but there may be some evidence of allergy in younger life. Patient VB may have had mild asthma as a child, and this has now been exacerbated by the increased incidence of wheeze. Question 2 reads, what are the risk factors for developing asthma? What risk factors does the patient have? The risk factors for developing asthma are as follows. 1. Atopy in a patient, which refers to a group of disorders which include asthma, eczema and hay fever. 2. Positive family history. 3. Circulating antibodies and developing IgE class against common environmental factors. 4. Genetic and environmental factors influencing levels of IgE. 5. Occupational hazards, e.g. exposure to reactive chemicals such as isocyanates or IgE-related, such as allergens from animals, flour and grain. 6. Non-steroidal anti-inflammatory drugs, NSAIDs, e.g. aspirin, which can precipitate an attack in 5% of people with asthma. 7. Beta blockers. There is some evidence that beta-adrenergic blocking drugs such as propranolol can cause bronchoconstriction in some patients. Some selectivity with beta-2 adrenergic drugs can minimize this effect, but caution should be exercised. 8. Atmospheric pollutants, e.g. cigarette smoke, car pollutants, and dust. 9. Cold air and exercise. People with asthma should ensure they are using effective medication since the latter can precipitate hyper-responsiveness of the airway. This patient has limited risk factors. However, recurrent episodes of wheeze and exposure to cold and exercise may have precipitated the attack. Question 3a reads, what is the pharmacology of beta-2 agonists and inhaled corticosteroids? Beta-2 adrenergic agonists are available as short and long-acting agents. These drugs have limited gastric absorption and are only effective when inhaled, following which they exert a local effect in the lungs. Beta-2 adrenergic agents cause bronchodilation by increasing the levels of cyclic adenosine monophosphate, abbreviated as CAMP, following stimulation of the beta-2 receptors in smooth muscle. They act throughout the respiratory tract. Short-acting beta-2 adrenergic agents are the drugs of choice for the acute management of asthma. Longer-acting beta-2 adrenergic agonists are used in patients with moderate to severe asthma in combination with corticosteroids. Corticosteroids are anti-inflammatory drugs and are available in a range of formulations. These drugs are used in the management of short and long-term control of asthma. A wide range of formulations and types of corticosteroids varying in potency are available. Inhaled corticosteroids are minimally absorbed and have a local effect. However, depending on the dose and potency of the inhaled corticosteroid, inhaled forms can produce systemic side effects. Oral prednisolone is rapidly absorbed and is metabolized by the liver. Some corticosteroids may be administered intravenously. Corticosteroids have a complex mechanism of action. They can affect the production of cytokines, leukotrienes and prostaglandins. This affects the production of eosinophils and release of other markers of the inflammatory response. Corticosteroids can affect other areas of the body and hence have a range of side effects. Question 3b reads, what are the side effects of beta-2 agonists? The adverse effects of beta-2 agonists are listed below. 1. Paradoxical bronchospasm. 2. Tachycardia. 3. Palpitations. 4. Tremor. 5. Restlessness. 6. Headache. 7. Blushing. 8. Dry mouth. 9. Hypertension. 10. Arrhythmia. And 11. Low potassium levels. Question 4 reads, what formulations of salbutamol and inhaled corticosteroids are available and what are the advantages and disadvantages? Next we will discuss salbutamol. Salbutamol is available as tablets, inhalers, nebulizer solution and intravenous injection. In the management of asthma at step 1 and 2, the inhaled formulation is the best option since it targets the drug and minimizes side effects. Oral tablets of salbutamol are rarely used and there is limited evidence of their effectiveness. Patients who have difficulty in coordination with inhalers can use a spacer device. These remove the need for coordination between actuation of a pressurized metered dose inhaler and inhalation. The spacer device reduces the velocity of the aerosol and subsequent impaction on the oropharynx. In addition, the device allows more time for evaporation of the propellant so that a larger proportion of the particles can be inhaled and deposited in the lungs. The size of the spacer is important. The larger spacers with a one-way valve, nebuhaler, or volumatic, being most effective. Spacer devices are particularly useful for patients with poor inhalation technique, for children, for patients requiring higher doses, for nocturnal asthma, and for patients who have poor coordination. Nebulized and intravenous salbutamol is required for more severe and acute status asthmaticus. And now we will progress to corticosteroids. Corticosteroids are available in tablet, inhaled and intravenous dosage forms. Inhaled corticosteroids allow the control of asthma with minimal systemic absorption and thus reduce the risks associated with corticosteroids such as osteoporosis and adrenal suppression. These risks are greatly increased when taking systemic corticosteroids. Oral tablets and intravenous steroids are used in more severe and acute status asthmaticus. Question 5 reads, describe how to use a metered dose inhaler abbreviated as MDI. Patient education is vital for the management of asthma. Patients should be guided in their use of the asthma inhaler. It is important that you then observe the patient's use. Instructions given to the patient are as follows. 1. Sit in a comfortable, upright position. 2. Remove the cap of the inhaler. 3. Shake the inhaler. 4. Breathe out and then put the mouthpiece into your mouth, and take a deep inhalation, simultaneously pressing the inhaler. 5. Hold your breath, then exhale slowly. 6. Wipe the mouthpiece and replace the lid. 7. The inhaler should be stored in a cool, dry place. The essential counseling points should be taken from the inhaler package insert. And lastly, 8. If you are to take 2 puffs, wait half a minute before repeating the steps above. Question 6 reads, what are the social implications of this man's asthma? The social implications of this man's asthma include the fact that VP is entering adult life and will need to be aware of the importance of effective asthma management. He has to be mature enough to take responsibility for his asthma management and must not feel inhibited by having to carry inhalers with him. He needs to ensure prophylactic cover with beta-2 agonists when undergoing strenuous exercise. He needs to be counseled on issues of sex education and the regular use of his inhalers. There is limited evidence of genetic malformation from his medicines, but the patient needs to be aware that when he considers a family, his child may be prone to asthma due to the genetic predisposition. Next we will discuss case study level 2 involving asthma of acute on chronic nature. Let's begin with the learning outcomes. On completion of level 2 case study, you will be able to accomplish the following. 1. Interpret relevant lab and clinical data. 2. Identify monitoring and referral criteria. 3. Explain treatment choices. 4. Describe goals of therapy including monitoring and the role of the pharmacist or clinician. And lastly 5. Describe issues such as counseling points, adverse drug reactions, drug interactions, complementary, alternative therapies and lifestyle advice. Let's briefly look at a clinical scenario. H.T., a 32-year-old woman, 155 centimeters, 81 kilograms, presents to hospital casualty with a history of increased breathlessness and wheeze over the last 5 days. She is known to have had asthma for 20 years and has smoked 10 cigarettes per day since the age of 15. Her last hospital admission was 1 month ago. She works in a small, do-it-yourself shop as a counter assistant. H.T. lives in a 10th floor council flat. She is single. On medical examination the following is found. 1. Audible wheeze throughout the chest, using accessory muscles. 2. She is not able to speak in sentences. She stops for breath after 2 words. 3. Tachycardia, i.e. a pulse of 130 beats per minute. 4. She is tachypneic, with a respiratory rate 25 breaths per minute. And 5. A peak expiratory flow rate 150 liters per minute. Question 1a reads, explain why this patient is tachycardic and tachypneic. Tachycardia is an increase in the heart rate over 100 per minute. This can be due to excessive use or side effects of a beta agonist. It can be induced by anxiety and panic, which a patient may experience during an asthma attack. Tachypnea is an increase in the respiratory rate due to airway narrowing and constriction, hence the body will increase its respiratory rate to try to increase the intake of oxygen. Question 1b reads, describe what peak expiratory flow measures and how this value is interpreted in this woman. This is a test to assess the degree of airway limitation. It is easy to perform and relatively inexpensive. The patient takes a full inspiration to total lung capacity and then blows out forcefully into the peak flow meter. The best of 3 recordings are normally taken. The peak flow measures the expiratory flow rate in the first 2 milliseconds of expiration and can overestimate the extent of lung function in patients with moderate to severe airway limitation. Other tests such as spirometry, forced expiratory volume in 1 second, abbreviated as FEV1, forced vital capacity, abbreviated as FVC, and the ratio of forced expiratory volume in 1 second to forced vital capacity are used. Let's now look at peak expiratory flow rate. Peak flow measurement of peak expiratory flow rate, abbreviated as PEFR, on waking, before bed, Before and after bronchodilator medication is useful to assess the extent of airflow limitation and the characteristic of the disease in terms of reversibility. There is some evidence of diurnal variability. Peak expiratory flow rate is also useful in assessing the disease progression longer term and the response to therapy. Patients are advised to keep an asthma diary and record regularly the peak flows to ascertain their diurnal pattern. The extent of reversibility can be assessed using peak expiratory flow rate. 15% improvement in the peak expiratory flow rate determines the extent of reversibility following bronchodilator therapy. This patient's peak expiratory flow rate that is 150 liters per minute is very limited. In a patient of her age and weight, her normal value would be 300 to 350 liters per minute, hence she is showing 50% or less than 50% of her best value, which indicates substantial airflow limitation. Question 1c reads, describe what other tests would be of importance in this patient at the time of admission. Other tests which would be helpful in this woman would be forced expiratory volume in 1 second, forced vital capacity and blood gases. The spirometry values provide data not only on the expiration of air, but also on the time taken for forced expiration. Patients with significant airway limitation will show a prolonged forced expiratory time. The forced expiratory volume in 1 second expressed as a percentage of the forced vital capacity provides a measure of the extent of airway limitation. In normal subjects it would be in the region of 75%. In patients with obstruction, the ratio forced expiratory volume in 1 second to forced vital capacity will be reduced. Blood gases would need to be checked. The normal for this patient would be 1. Oxygen saturation above 95%. 2. pH 7.3 to 7.5. 3. pCO2 4 to 6.7 kilopascals. And 4. PO2 11 to 13 kilopascals. Question 1d reads, explain how the severity of acute asthma is estimated and how often investigations should be done. Patients should be routinely assessed by the general practitioner or pharmacists at least every 3 months. Once a patient is stable, most assessments will be carried out annually by the general practitioner or clinical nurse specialist. Pharmacists should routinely review the patient if medication alters and at least every 3 months. The following symptoms should be assessed. 1. Episodic wheeze. 2. Cough. 3. Shortness of breath. And 4. Number of attacks. Investigations include the following. 1. Peak expiratory flow rates. 2. Lung function tests. 3. Histamine or methicillin bronchial provocation tests for severe cases, rare. And 4. Skin prick tests to identify allergens. The severity is also assessed according to which step of treatment the patient is on. BTS, Sign, 2008. Clinical features of acute severe asthma include the following. 1. Inability to complete sentences. 2. Respiratory rate higher than 25 breaths per minute. 3. Tachycardia 110 beats per minute. 4. PEFR 33 to 50% of patients best or predicted. Life-threatening characteristics include 1. Silent chest and cyanosis. 2. Exhaustion, confusion and coma. 3. Bradycardia or hypotension. 4. Peak expiratory flow rate less than 33% of patients best or predicted. And 5. Blood gases, PaCO2 of 4.6 to 6 kPa, and a PaO2 less than 8 kPa. Question 2 reads, list the medicines available for the acute treatment of asthma and describe the method of administration. Patients will be prescribed inhalers and tablets and, at a later stage, nebulizers may be used. Asthma is managed in a stepwise approach using the British Thoracic Society and Scottish Intercollegiate Guidelines Network, 2008. Details are available in the British National Formulary, BNF. Summary 1. Step 1 Occasional bronchodilator relief. Inhaled short-acting beta-2 agonist as required. 2. Step 2 Regular inhaled preventer therapy. Inhaled short-acting beta-2 agonist as required and regular standard dose inhaled corticosteroid. 3. Step 3 Inhaled corticosteroid and long-acting inhaled beta-2 agonists. Inhaled short-acting beta-2 agonist as required and regular standard dose inhaled corticosteroid and regular inhaled long-acting beta-2 agonist plus at this step either leukotriene receptor antagonist or modified-release oral theophylline or modified-release oral beta-2 agonist therapy may be considered. 4. Step 4 High-dose inhaled corticosteroid and regular bronchodilators. Inhaled short-acting beta-2 agonist as required and regular high-dose inhaled corticosteroid and inhaled long-acting beta-2 agonist plus 6-week sequential trial of one or more of leukotriene receptor antagonist or modified-release oral theophylline or modified-release oral beta-2 agonist. 5. Step 5 Patient would be on Step 4 then add in regular corticosteroid tablets. The most important issues in the management of asthma are effective therapeutic management. Virchow and colleagues in 2007 have clearly identified that the use of inhaler devices is crucial to effective clinical management. The study suggests several issues that influence treatment, including the following. 1. Poor understanding of treatment guidelines in terms of content, implementation and relevance to everyday clinical life. 2. Insufficient patient education. 3. Lack of access to healthcare and cost of medication. And 4. Poor inhaler technique. Pharmacists have a key role to play in education since inhalation therapy is a vital component of effective asthma management. Question 3a reads, describe the role of the pharmacist in the care of this patient. Pharmacists are responsible for the following. 1. Ensuring that the patient understands their condition and can recognize the signs of acute deterioration and risk of status asthmaticus. 2. Counseling the patient on the medication and ensuring they know why, when and how to take the medicines. 3. Ensuring that patients know how to monitor the effectiveness of the therapy. 4. ensuring that patients know how often they should visit their general practitioner and ensure appropriate clinical tests are completed, and 5. Effective medicines management. Question 3b reads, what are the aims of asthma treatment for the patient and the professional? The aims of asthma treatment are as listed below. 1. Effective control of asthma symptoms. 2. Positive quality of life. And 3. Minimal acute hospital admissions. Question 4a reads, explain the social issues this patient will face on discharge. T will need to deal with medicines management including supply, impact on her lifestyle and importance of concordance, and lifestyle issues, such as exercise and sport. Question 4b reads, critically review the non-pharmacological therapies that are available for people with asthma. Would these be of benefit for this patient? Non-pharmacological recommendations could include those listed below. 1. Lifestyle advice, e.g. exercise management and stop smoking. 2. The avoidance of precipitating factors, i.e. pollutants, house dust mite, grass pollen and/or fungal spores, by the use of special vacuum cleaners for the house and regular change of bedding. 3. Flu vaccinations. 4. The avoidance of certain medicines, e.g. non-steroidal anti-inflammatory drugs, aspirin and beta blockers. And 5. Occupational hazards, e.g. veterinary medicine, bakery and laundry work. The above parameters are known to be associated with exacerbation of asthma, and hence patients need to have an understanding of how to manage their treatment. Question 4c reads, discuss the role of an asthma management plan for this patient. The object of an asthma management plan is to ensure the patient 1. Understands the disease, 2. Can describe the medicine, why it is prescribed and how it should be used, 3. Is monitored effectively, 4. Has appropriate health outcomes, and 5. Has effective chronic disease management and prevents exacerbations and hospital admissions. The pharmacist is responsible for preparing a pharmaceutical care plan for this patient and must include the issues listed in Table A 3.1. Pause the video and carefully scrutinize Table A 3.1 before proceeding to the next slide. Next we will discuss Case Study Level 3 involving chronic obstructive pulmonary disease, abbreviated as COPD, with comorbidity. Let's begin with the learning outcomes. On completion of Level 3 case study, you will be able to accomplish the following. 1. Interpret clinical signs and symptoms. 2. Evaluate laboratory data. 3. Evaluate treatment options. 4. State goals of therapy. 5. Describe a pharmaceutical care plan to include advice to a clinician. 6. Describe the prognosis and long-term complications. And 7. Describe the social pharmacy issues which could include supply, e.g. complex treatments at home, concordance and compliance, and lifestyle issues. Next we will briefly discuss a clinical scenario. A 63-year-old woman, weighing 67 kilograms, is admitted to hospital with chest pain, shortness of breath and sweating. She is seen in casualty and treated using a salbutamol nebulizer. She looks obese. She has been a lifelong smoker who stopped 1 day ago. Her previous medical history includes chronic obstructive pulmonary disease, COPD, for 10 years. Last admission to hospital was 2 weeks ago. Ischemic heart disease since 1995. Myocardial infarction 4 years ago. Osteoporosis diagnosed 3 years ago. Hypertension diagnosed 9 years ago. And pulmonary embolism 2 months ago. On examination, the following are the outcomes. 1. Blood pressure 105 systolic 90 diastolic. 2. Heart rate 90 beats per minute. And 3. Respiratory rate 20 breaths per minute. Arterial blood gases on admission are as follows. 1. pH of 7.388 on 35% oxygen. 2. PCO2 of 9.67 kilopascals. And 3. PO2 of 6.5 kilopascals. Oxygen saturation, SP. O2 is 89%. Lungs hyperinflated. There is no wheeze. There are a few right base crepitations. Laboratory tests at admission are as follows. A WCC of 16.5 times 10 power 9 per liter. The normal range is 4 to 11 times 10 power 9 per liter. Sodium levels of 140 millimoles per liter. The normal range is 135 to 145 millimoles per liter. Potassium levels of 4.4 millimoles per liter. The normal range is 3.5 to 5 millimoles per liter. Creatinine of 75 micromoles per liter. The normal range is 59 to 104 micromoles per liter. Urea of 7.8 millimoles per liter. The normal range is 1.7 to 8.3 millimoles per liter. Hemoglobin of 11.6 grams per deciliter. The normal range is 13 to 17 grams per deciliter. Medication on admission are listed below. 1. Prednisolone 10 mg once daily. 2. Fluticasone inhaler 500 micrograms inhaled twice daily. 3. Aspirin 75 mg once daily. 4. Bumetanide 1 mg once daily. 5. Combivon nebs 2-4 times daily. 6. Enalapril 5 mg once daily. 7. Unifilan continues 200 mg twice daily. 8. Senna 2 tablets at night. 9. Warfarin 5 mg once daily. 10. Zopiclone 7.5 mg at night. 11. Diclofenac 50 mg as needed up to thrice daily. And 12. Oxygen 2L via nasal specs. Question 1a reads, describe the clinical signs and symptoms of chronic obstructive pulmonary disease. Explain the pathophysiology and how these relate to the patient. The clinical signs and symptoms of chronic obstructive pulmonary disease. The pathophysiology and how this relates to the patient are explained in Table A3.2. Pause the video and carefully scrutinize Table A3.2 Clinical signs and symptoms of chronic obstructive pulmonary disease. The pathophysiology and how this relates to the patient in Case Study Level 3 before proceeding to the next slide. Question 1b reads, what is the interpretation of this patient's pulse oximetry and arterial gases? Pause the video and carefully scrutinize Table A3.3 interpretation of this patient's pulse oximetry and arterial gases before proceeding to the next slide. Question 1c reads, describe the clinical difference between asthma and chronic obstructive pulmonary disease. Pause the video and carefully scrutinize Table A3.4 summarizing asthma and chronic obstructive pulmonary disease compared before proceeding to the next slide. Question 2 reads, comment on the current drug therapy and describe the role of oxygen in this patient. Pause the video and carefully scrutinize Table A3.5 summarizing the current drug therapy for the patient in Case Study Level 3 before proceeding to the next slide. Pause the video and carefully scrutinize Table A3.5 summarizing the current drug therapy for the patient in Case Study Level 3 before proceeding to the next slide. We will now discuss the role of oxygen. As this patient has a PaO2 of less than 7.3 kPa and oxygen saturation of arterial blood of less than 90%, she is eligible for long-term oxygen therapy, abbreviated as LTOT. She will need to use oxygen at least 15 hours a day and needs to be counseled on the importance of smoking cessation. Ambulatory and short-burst oxygen therapy should also be considered, as per NICE guidelines, as published by NICE in 2004. Question 3 reads, describe the care plan for this patient, including smoking cessation. One. Check patient understanding of therapy. Discuss with the patient the role of each medicine. Check inhaler technique. And discuss the need to have regular blood pressure checks. 2. Offer smoking cessation. All patients should be encouraged to stop smoking. NICE guidance available. Initial supply to last 2 weeks after target stop date. And offer nicotine replacement. Bupropion or varenicline can be considered. 3. Review the use of nebulizers. Review the need for nebulization, check inspiratory flow rate. And consider use of tiotropium. 4. Review of changes in treatment. Discuss with general practitioner the changes in medicines, especially the warfarin and pain control. 5. Check the plan for acute exacerbations. Discuss with patient and general practitioner what plan is in place. 6. Review the need for bone protection. Osteoporosis is present. Need to check why no bone protection medication has been given. Therefore start if no contraindications. 7. Check understanding of anticoagulation. Careful monitoring of INR. Question 4 reads, what are the key aims for this patient and the professional? Pause the video and carefully scrutinize Table A 3.6 summarizing the key aims for the patient and the professional before proceeding to the next slide. Question 5 reads, explain how spirometry can be used to monitor this patient. The degree of airflow obstruction should be assessed using the following. 1. Forced expiratory volume in 1 second less than 80% predicted is airway obstruction. 2. Forced expiratory volume in 1 second to forced vital capacity ratio less than 0.7 is airway obstruction. 3. Vital capacity, version C, and 4. Peak expiratory flow, less informative than spirometry. Normal forced expiratory volume in 1 second excludes chronic obstructive pulmonary disease as a diagnosis. A normal peak flow does not. The patient inhales maximally and then exhales as forcefully as possible. The volumes recorded are compared with predicted values based on age, sex and height. The ratio of forced expiratory volume in 1 second to forced vital capacity airflow obstruction is diagnosed, as well as the severity. The vital capacity in chronic obstructive pulmonary disease may be greater than the forced vital capacity, because of floppy airways. Spirometry does not distinguish between airflow obstruction due to asthma and chronic obstructive pulmonary disease, but in conjunction with reversibility testing it can do so. Forced expiratory volume in 1 second can therefore be diagnostic, assess severity and prognosis and monitor progression of disease. Question 6 reads, what are the social issues in treating this patient at home? Patients may be anxious and refuse such support. The cultural and social setting of the patient needs to be taken into account. As patients lose their mobility and increase dependence on others for help with day-to-day living, anxiety increases. Patients can become hesitant to seek help because of the perception that their condition was self-inflicted. Poor populations tend to have a higher risk of developing chronic obstructive pulmonary disease. Other factors include poor nutrition, crowding, exposure to pollutants, poor access to healthcare and early respiratory infections. Some evidence suggests women are more susceptible to chronic obstructive pulmonary disease development than men. A multidisciplinary team should be involved in the support of the patient at home. Additional use can be made of nebulizers, compressors, oxygen, visiting respiratory nurses, and increased social service input. The patient remains under care of the hospital, but the general practitioner is made aware of the extra support. Health status is better in home-treated patients. Chronic obstructive pulmonary disease is linked with other comorbid conditions. Patients are more likely to have ischemic heart disease, pneumonia, and diabetes, making treatment more complicated and requiring a holistic approach to care. This patient demonstrates 5 comorbidities. These in turn impact on the medication load she has to cope with, so concordance is important. Next we will discuss case study level EMA involving chronic obstructive pulmonary disease. Let's begin with the learning outcomes. On completion of level M case study, you will be able to accomplish the following. 1. Interpret clinical signs and symptoms. 2. Evaluate laboratory data. 3. Critically appraise treatment options. 4. State goals of therapy. 5. Describe a pharmaceutical care plan to include advice to a clinician. 6. Describe the prognosis and long-term complications. 7. Describe the social pharmacy issues which could include supply, e.g. complex treatments at home, concordance and compliance, and lifestyle issues. And 8. Describe the monitoring of therapy. We will now briefly discuss a clinical scenario. Mr. C.D., a 75-year-old man, who is 1.7 meters tall, is admitted to hospital very short of breath. He used to work in the docks as a clerk and has smoked 40 cigarettes daily for 30 years and stopped 2 years ago. His previous medical history includes chronic obstructive pulmonary disease, recurrent infective exacerbations since 1991. He receives no long-term oxygen therapy. Type 2 diabetes mellitus on insulin 14 international units twice daily for 20 years. Retinopathy, ischemic heart disease. He has undergone coronary artery bypass graft twice. Hypertension, myocardial infarction 1986, atrial fibrillation, and high cholesterol. The patient was discharged from hospital 3 weeks ago with antibiotics. There was some improvement, but he is still very short of breath at rest. 5 days ago, with worsening shortness of breath over the previous week, the patient took clarithromycin 500 mg twice daily. 4 days ago he took prednisolone 30 mg daily, but has now stopped, with no improvement. He is using nebulizers 7 times daily, using salbutamol plus ipratropium. Because he was no better today, his daughter called an ambulance. On arrival he had shortness of breath on exertion after 2 yards, best 30 yards, cough which is chronic, no worse, none productive, chronic wheeze, no chest pain, no palpitations, ankle swelling no worse than usual, both legs swollen to upper calf, orthopnea. The patient sleeps upright and gets paroxysmal nocturnal dyspnea if lying flat. Regarding a systems review: 1. Bowels were okay. 2. In the genitourinary system poor stream was noted. There was no hematuria, no dysuria. There was nocturia times 4 to 5. 3. There were no allergies. Regarding medicines, the patient's medications comprise of the following. 1. Aspirin 300 mg once daily. 2. Diltiazem MR, marketed as Tildem LA, dosed at 300 mg once daily. 3. Bendroflumetazide 2.5 mg once daily. 4. Losartan 50 mg once daily. 5. Furosemide 80 mg once daily. 6. Atorvastatin 10 mg once daily. 7. Carbocysteine 500 mg 4 times daily. 8. Insulatard 14 international units twice daily. 9. Ferrous sulfate 300 mg THTICE daily. 10. Omeprazole 20 mg once daily. 11. Alendronate 70 mg weekly. 12. Salbutamol 2.5 mg nebulized as needed. And 13. Ipratropium 500 micrograms thrice nebulized. He is an ex-smoker who stopped 2 years ago. Alcohol very occasionally. Retired clerk. On examination. Degree J, degree A, degree C, degree C, degree L. Mr. CD's pulse rate is 115 irregular and his respiratory rate is 40 breaths per minute. He has bilateral crepitations and forced expiratory volume in 1 second 1.2 liters. His laboratory tests are listed below. WBC 15.8 times 10 power 9 per liter. The normal range is 4 to 11 times 10 power 9 per liter. Hemoglobin 11 grams per deciliter. The normal range is 13 to 17 grams per deciliter. Neutrophils 14.4 times 10 power 9 per liter. The normal range is 1.5 to 7 times 10 power 9 per liter. Lymphocytes 0.5 times 10 power 9 per liter. The normal range is 1.2 to 3.5 times 10 power 9 per liter. Troponin T of 0.02 micrograms, the normal range is less than 0.03 micrograms. Sodium levels of 135 millimoles per liter. The normal range is 135 to 145 millimoles per liter. Potassium levels of 4.0 millimoles per liter. The normal range is 3.5 to 5 millimoles per liter. Urea of 6.9 millimoles per liter. The normal range is 1.7 to 8.3 millimoles per liter. Creatinine 81 micromole. The normal range is 59 to 104 micromole. Magnesium of 0.67 millimoles per liter. The normal range is 0.65 to 1.05 millimoles per liter. GGT 169 international units per liter. The normal range is 4 to 72 international units per liter. ALT 35 international units per liter. The normal range is 4 to 59 international units per liter. Bilirubin of 11 millimoles per liter. The normal range is less than 16 millimoles per liter. Albumin 47 grams per liter. The normal range is 40 to 52 grams per liter. CRP 16 mLLi grams per liter. The normal range is less than 4 mLLi grams per liter. Glucose 18.2 millimoles per liter. The normal range is 3.8 to 5.5 millimoles per liter. A diagnosis of infective exacerbation of chronic obstructive pulmonary disease with heart failure is made. Question 1 reads, discuss the clinical signs and symptoms for Mr. CD. Pause the video and carefully scrutinize Table A 3.7 before proceeding to the next slide. Question 2a reads, discuss the role of smoking history and calculate the total pack years this patient has been subjected to. Cigarette smoking is the single most important risk factor for the development of chronic obstructive pulmonary disease. Stopping smoking as chronic obstructive pulmonary disease becomes more severe has limited impact on its progression. Smokers with impaired lung function are likely to die from complications of atherosclerotic vascular disease. Far more than 15% of smokers get chronic obstructive pulmonary disease. With enough smoking, all will have reduced lung function. Some smokers are very susceptible to impaired lung function. Smoking, including occupational exposure, is not the only cause of chronic obstructive pulmonary disease. Total pack years is calculated by multiplying the number of cigarettes per day by the number of years smoked and dividing by 20. In Mr. CD's case this is 40 multiplied by 30 all divided by 20, which amounts to 60 pack years. Question 2b reads, what spirometry should be used to assess Mr. CD's lung function and what main factors affect the predicted values? There is no single diagnostic test for chronic obstructive pulmonary disease. Airflow obstruction is equal to forced expiratory volume in 1 second and forced expiratory volume in 1 second to forced vital capacity less than 0.7. Mr. CD's forced expiratory volume in 1 second is equal to 1.2 liters. And that predicted for an 80 kg individual is equal to 4.7 L. That is 25%. Therefore below 30% predicted with severe airflow obstruction. Daily monitoring of peak expiratory flow should not be performed routinely as changes are very small, but it should be measured before discharge. Reference values may lead to underdiagnosis in the elderly. This is not applicable in Black and Asian populations. The values for the Black population are 10 to 15% lower than for white people of similar build. Chinese have been found to have a forced vital capacity about 20% lower and Indians about 10% lower than matched white populations. Question 3 reads, discuss the role of oxygen and delivery systems during the acute exacerbation. Oxygen saturation should be measured if there are no facilities to measure arterial blood gases. Do not exceed oxygen saturation of 93%. Start oxygen at 40% and monitor for drowsiness or saturations rising to 93 to 94%. Blood gases must be repeated according to response. Oxygen is given to keep saturation greater than 90%. Driving gas for nebulized therapy must be specified in the prescription. If oxygen is needed during nebulizer therapy, nasal cannulae should be used. Care must be taken with the nasal route, as it is difficult to predict the amount of oxygen inspired. Question 4a reads, critically review Mr. CD's list of medicines. Mr. CD's medications are reviewed in Table A3.8. This patient will need a course of antibiotics. Pause the video and carefully scrutinize Table A 3.8 review of Mr. CD's medicines before proceeding to the next slide. Question 4b reads, discuss the place and route of corticosteroids in Mr. CD's management. Inhaled corticosteroids do have a role in chronic obstructive pulmonary disease. They should be prescribed for patients with a forced expiratory volume in 1 second equal to or less than 50% predicted, with 2 or more exacerbations in 12 months that require antibiotics or oral corticosteroids. These patients are still breathless despite monotherapy with a long-acting beta-2 agonist. Maintenance use of oral corticosteroids is not recommended, but some patients with advanced chronic obstructive pulmonary disease may require them. Oral corticosteroids should be used in all patients admitted to hospital with an exacerbation of chronic obstructive pulmonary disease. There is insufficient evidence to establish the minimum dose of inhaled corticosteroids to obtain benefit, as published by Nice in 2004. Question 5 reads, describe a pharmaceutical care plan for the continued treatment of this patient. A pharmaceutical care plan is outlined in Table A 3.9. Pause the video and carefully scrutinize Table A 3.9 summarizing a pharmaceutical care plan for Mr. CD before proceeding to the next slide. A pharmaceutical care plan is outlined in Table A 3.9. Pause the video and carefully scrutinize Table A 3.9 summarizing a pharmaceutical care plan for Mr. CD before proceeding to the next slide. Next we will discuss Case Study Level MB involving brittle asthma. Let's begin with learning outcomes. On completion of Level M case study, you will be able to accomplish the following. 1. Interpret clinical signs and symptoms. 2. Evaluate laboratory data. 3. Critically appraise treatment options. 4. State goals of therapy. 5. Describe a pharmaceutical care plan to include advice to a clinician. 6. Describe the prognosis and long-term complications. 7. Describe the social pharmacy issues which could include supply, e.g. complex treatments at home, concordance and compliance, and lifestyle issues. And 8. Describe the monitoring of therapy. Let's briefly discuss a clinical scenario. A 22-year-old woman, Muzar J., is admitted via casualty with sudden breathlessness and wheeze. She has had asthma for 10 years and her last hospital admission was a month ago. She is usually on salbutamol nebs, and at home uses them once or twice weekly, budesonide turbo 800 micrograms 4 times daily, ipratropium nebs. Muzar J was on 40 mg prednisolone daily since last hospital discharge, but this was increased by the general practitioner a week ago for an upper respiratory tract infection. Recently Muzar J has bought some painkillers from her local pharmacy. The patient is allergic to penicillin and house dust. She is single, a money dealer and non-smoker. On examination the following are observed. 1. Audible wheeze. She is using accessory muscles. 2. She is not able to speak in sentences. 3. Her pulse is 130 beats per minute. She has a respiratory rate of 25 breaths per minute, and a blood pressure of 110 systolic 80 diastolic. 4. She has a peak expiratory flow rate 200 liters per minute. Her best value is 450 liters per minute. And 5. She is apyrexial. She has a dry cough. Her laboratory tests yielded the following results. WBC of 6.7 times 10 power 9 per liter. The normal range is 4 to 11 times 10 power 9 per liter. Hemoglobin of 11.2 grams per deciliter. The normal range ISB 13 to 17 grams per deciliter. Arterial blood gases 1. pH 7.388 on 60% O2. The normal range is 7.3 to 7.5. 2. A PCO2 of 4.67 kilopascals. The normal range is 4.0 to 6.7 kilopascals. 3. A PO2 of 24.7 kilopascals. The normal range is 11 to 13 kilopascals. 4. Oxygen saturation of 99.6% on oxygen. After 48 hours she has some spirometry tests which show forced expiratory volume in 1 second greater than 20% increase after salbutamol. After 72 hours in hospital, J is ready for discharge. Medication on discharge is suggested to be as listed below. 1. Salbutamol nebulizer 5 mg as needed. 2. Salmeterol inhaler 100 micrograms twice daily. 3. Budesonide inhaler 800 micrograms twice daily. 4. Theophylline SR 200 mg twice daily. 5. Prednisolone 50 mg daily. And 6. Omeprazole 20 mg once daily. Question 1 reads, using the data provided, assess the severity of the asthma. The severity of Mus-Rj's asthma is assessed in Table A 3.10. Pause the video and carefully scrutinize Table A 3.10 summarizing the assessment of severity of asthma before proceeding to the next slide. Question 2 reads, explain the blood gases on admission. Mus-Rj's blood gases are explained in Table A 3.11. Pause the video and carefully scrutinize Table A 3.11 explanation of Mus-Rj's blood gases before proceeding to the next slide. Tissue hypoxia occurs within 4 minutes of failure to deliver adequate supply. Hyperventilation due to carotid chemoreceptor stimulation becomes noticeable when PO2 falls to 5.3. Arterial oxygen saturation should be between 95 to 100%. This patient has a good saturation figure of 99.6%. Question 3a reads, describe the role of Mus-Rj's discharge therapy. Mus-Rj's discharge therapy is outlined in Table A3.12. Pause the video and carefully scrutinize Table A3.12 megaseconds Rj's discharge therapy before proceeding to the next slide. Question 3b reads, critically review the role of magnesium in acute asthma. Magnesium has been established in clinical practice in acute emergency therapy as an adjunct to standard treatment with bronchodilators and corticosteroids. Magnesium has bronchodilatory effects, the exact mechanism of action of which is unclear, as it affects a number of pathways. A single dose of IV magnesium sulfate 1.2 to 2 grams over 20 minutes is recommended, according to BTS Sign guidelines in 2008. Repeated doses have not been assessed. Repeated doses can cause hypermagnesemia, causing respiratory depression. Question 3c reads, discuss the issue of non-steroidal anti-inflammatory drugs in asthma. Aspirin-induced asthma has an onset of 30 minutes to 3 hours after ingestion. Affected individuals are cross-sensitive to all non-steroidal anti-inflammatory drugs. Paracetamol is seldom associated with cross-sensitivity in patients with aspirin-induced asthma. Aspirin-induced asthma is believed to involve inhibition of COX-1. Patients should be provided with information on which drugs these are. Question 4a reads, describe the role of theophylline in asthma. Theophylline has several effects which have been described, especially in asthma. 1. Bronchial smooth muscle relaxation. 2. Increase in mucociliary clearance. 3. Inhibition of release of mediators. 4. Decrease of pulmonary hypertension and increase in right ventricular ejection fraction. 5. Improved contractility of fatigued diaphragmatic muscle. And 6. Central stimulation of ventilation. Possible mechanisms include the following. 1. Inhibition of cyclic nucleotide phosphodiesterase. 2. Interaction with guanine nucleotide regulatory proteins, G proteins. 3. Adenosine antagonism. 4. Effects via increased catecholamine release. And 5. Inhibition of the formation of intracellular second messengers such as inositol triphosphate. Intravenous aminophylline is used in patients with a poor response to initial therapy. Levels must be measured. Question 4b reads, critically review the role of anti-IgE monoclonal antibody for Mus-Rj. Anti-IgE monoclonal antibody, i.e. omalizumab, is of benefit in highly selected patients. It is given fortnightly or monthly as a subcutaneous injection. It is licensed for use by doctors experienced in severe persistent asthma. Published evidence in severe allergic asthma is poor. Trials so far have been relatively short-term. There is a large variation in annual cost. This is partly because the dose is determined by a patient's IgE level and body weight. There is a lack of data on suppressing serum IgE systems long-term. Omalizumab is licensed as add-on therapy in patients with the following: 1. Positive skin test for an aeroallergen. 2. Forced expiratory volume in 1 second below 80%. 3. Multiple daytime or nighttime symptoms. 4. Frequent documented exacerbations. And 5. Have been having standard therapy, i.e. high-dose inhaled corticosteroids, more than 800 micrograms of beclometasone, and long-acting inhaled beta-2 agonists. Omalizumab should only be used if the asthma is IgE-mediated. It has been reported that patients requiring daily prednisolone to control their asthma are unlikely to respond. This lady is already on high-dose oral corticosteroids and long-acting inhaled beta-2 agonists, but with no details of her IgE level, and this needs to be checked before a decision is made. Question 5a reads: discuss the issues in variability of peak expiratory flow. The term brittle asthma was first used in 1977 to describe patients who maintained a wide variation in peak expiratory flow rate despite high-dose inhaled steroids. This has been reviewed and described by Ayres and colleagues in 1998, based on the magnitude of diurnal peak expiratory flow rate variability, rather than the pattern of variability. They also describe two subclasses: maintained wide peak expiratory flow variability, type 1, greater than 40% diurnal variation for more than 50% of the time over at least 150 days, or sudden onset of acute airway obstruction, type 2, occurring in less than 3 hours without obvious trigger. Peak expiratory flow is effort-dependent and thought to measure large-caliber airway function. Forced expiratory volume in 1 second has both effort-dependent and effort-independent characteristics. It is thought to measure intermediate and smaller airways. Peak expiratory flow should be recorded as the best of 3 forced expiratory blows with a pause of 2 seconds before each. The patient can be either standing or sitting. Peak expiratory flow variability is calculated as the difference between the highest and lowest peak expiratory flow, expressed as a percentage of either the mean or highest peak expiratory flow. Question 5b reads: what other therapy could be considered? Devise a care plan. Other treatments to be considered are listed below. 1. Increase budesonide to 2000 micrograms daily. 2. Leukotriene receptor antagonists. 3. Methotrexate. 4. Cyclosporin. 5. Oral gold. And 6. Subcutaneous terbutaline infusion. Regarding the care plan before discharge: 1. Check use of inhalers. 2. Advise patient to make an early follow-up appointment with the general practitioner. 3. Check patient can use a peak flow meter and that they know at what stage to seek medical help. And 4. Check patient has an asthma self-management plan. Question 6 reads, discuss the factors that predict poor compliance with asthma treatment. Adherence to prophylactic asthma medications is affected by many factors as listed below. 1. Age. Younger adults have less adherence than older working-age adults. Problems may arise in the elderly due to poor coordination, vision and cognitive impairment. 2. Cost of treatment. 3. Educational level. 4. Lower socioeconomic status. 5. Fear of dependency and lack of control. 6. Lack of insight into illness. 7. Complexity of treatment. 8. Effect of peer pressure to appear normal. 9. Duration of disease. 10. Concern over side effects of treatment. And 12. Poor concordance. Simple written instructions increase compliance. Thank you.